Okay, good morning, everyone, and welcome to the last grand rounds of 2020. We will be going on a brief winter hiatus for the rest of the year, but we're looking forward to welcoming you back in early January with a new batch of educational and thought-provoking talks. For our last session of 2020, we have what has quickly become one of my favorite grand rounds of each year. Head Talks was started in 2014 by our current residency program director, Dr. Katrina DeBonis, as a way of highlighting some of our trainees who have agreed to bravely step in front of the microphone and talk about some of the topics that they're most passionate about. These talks are quick, they're about 10 minutes long, and they're meant to introduce some of the most exciting, innovative, and interesting ideas that will likely have a major impact on our field soon. So now I'm pleased to present our 5th annual Head Talks featuring Drs. Collin Price, Michael Mensah, and Richie Loeb. I've been incredibly fortunate to have worked with all 3 of them over the past few years, and I'm very much looking forward to hearing what they have to say. If you have any questions, feel free to put it in the Q&A at any point. With that being said, I will hand it over to Dr. Mary Youssef to introduce the first speaker of the morning.
Hello, everyone. I'm excited to introduce Dr. Collin Price, a second-year psychiatry resident at UCLA and one of my classmates. Collin is going to be speaking to you about psychedelic-assisted psychotherapy. Collin and I spoke about this topic a couple of months ago as we were discussing our interests in psychiatry. Before our conversation, I have to say I had a pretty negative view of psychedelics and was skeptical about their use in psychiatry. However, as Collin described how psychedelics have been tested in psychiatry and the impressive results, I was surprised and intrigued. My mindset completely changed in a span of 30 minutes. I'm eager to have him share this talk with you and potentially open your minds to this exciting new treatment approach.
Thank you very much for that introduction, Mary, and thank you everyone for joining us today. I'm really excited to talk about this topic. I've been interested in psychedelics for a few years, and I think they represent a very exciting future for our field. Let me get my screen up here. All right. So let's start with a story about Octavian. Octavian was stuck in anxiety. Even after his Hodgkin's lymphoma went into remission, he couldn't shake the feeling that the cancer would come back. He would compulsively feel at his neck for swollen lymph nodes and canceled a trip out of the country for fear of being away from oncologists. When it got to the point that he was drinking excessively just to get through the day, his doctor handed him a pamphlet about cancer-related anxiety. A few months later, after a couple meetings with research therapists, Octavian sat in a comfortable room at NYU. He took a pill from a large ceremonial chalice, laid back on a couch with eye shades and headphones, and turned his attention inward. Over the next several hours, Octavian experienced a whirlwind of dreamlike imagery and intense emotions. At one point, he watched as black smoke rose from his body, and he felt an incredible sense of relief. The next day, in processing the intense experience with his therapist, he told them he was no longer scared of his cancer. 3 years later, he remained free of the once crippling anxiety and said that the experience had made his life richer. Octavian was part of one of the first studies in what's been dubbed the psychedelic renaissance. In multiple small-scale randomized clinical trials, psychedelics have shown rapid effects in the treatment of a variety of psychiatric conditions. In treatment-resistant PTSD, patients saw significant improvements 3 days after MDMA-assisted psychotherapy, with roughly 70% of patients in remission at 1 month. And 1 week after 2 psilocybin-assisted psychotherapy sessions, roughly half of patients with depression were in remission. Perhaps more striking than the rapid onset of these effects is how long they last. 1 year after the MDMA sessions for PTSD, 2/3 of patients no longer met diagnostic criteria. A single psilocybin-assisted therapy session for smoking cessation led to 60% abstinence at 1 year, compared to just 27% using the patch. And in patients with existential distress related to cancer diagnoses, the 50% remission rates they saw immediately after psilocybin therapy persisted as long as 4.5 years. These are unprecedented results in the field of psychiatry, naturally garnering a lot of hype, as well as a healthy dose of skepticism. Could a few intense psychedelic experiences paired with supportive psychotherapy really have such profound and lasting effects on this wide range of diseases? If the effects are real, how are these drugs producing such dramatic changes in our brains? Today, I'd like to explore this rapidly developing field and what it might look like to bring psychedelic therapy to the clinic. So what do we mean when we talk about psychedelics? The word psychedelic means mind manifesting or mind revealing, and there are many chemicals that are at times included under this umbrella term. The most commonly studied of these chemicals in relation to psychiatry include LSD, psilocybin, DMT, a component of ayahuasca, MDMA, and ketamine. The classic psychedelics, like LSD, psilocybin, and DMT, are defined by a very specific pharmacology, which is based on their similarity to serotonin. The activity of these chemicals at the serotonin 2A receptor subtype in particular is key to their psychedelic effects. Drugs with higher affinity for this receptor have stronger effects, and blocking this receptor blocks the psychedelic effects. At relatively low doses, psychedelics tend to promote social connectedness and a sense of well-being. At moderate doses, perceptual changes are common, such as objectively intense colors and the perception of movement in stationary objects. At high doses, there are dramatic changes in one's subjective experience. These changes can include a loss of sense of self and time, and a feeling of profound unity and interconnectedness. The effects of these higher doses are often described as spiritual or mystical, and are similar to the peak experiences described in non-drug states, such as expert meditation. These profound peak experiences are actually the goal in psychedelic-assisted psychotherapy. Multiple studies have found an association between mystical experiences and improved patient outcomes. And these experiences leave lasting imprints on the participants beyond their improved symptoms. Roughly 3/4 of participants rate their psychedelic therapy session as among the top 5 most personally and spiritually meaningful events in their life, compared to the birth of a child or the death of a family member. What is it about the action of these chemicals at the serotonin 2A receptor that produces such dramatic and lasting effects? The short answer is, we don't know, but there are some compelling theories. The serotonin 2A receptor has particularly high expression in areas of the brain known as association cortex. The neural networks composed of these regions, like the default mode network, are thought to be responsible for constructing models that help us predict what will happen in our worlds. Under normal circumstances, these networks are well defined, demonstrated here by lots of lines within the colored networks and few lines between the colors. The models of the world generated by these networks exert a strong top-down influence over the information that we take in. These models filter out stuff that doesn't fit well with our pre-existing beliefs, and over time they can become entrenched and rigid. Psychedelics are known to increase functional connectivity between these regions of the brain, shown by the many lines between the different colored networks. This is theorized to weaken the top-down influence of our models of the world, allowing information in that would normally be silenced. Like melting down steel so that it can form new shapes, psychedelics promote cognitive flexibility, allowing us to change our beliefs. One of the leading researchers in the field uses an analogy of a ski slope to illustrate this process. Imagine each thought as a skier going down the slope, making a groove in the snow. Following the same path over and over makes it easier and easier to fall into that groove. These are like the entrenched beliefs we develop over time. Psychedelics act like fresh powder covering the slope, allowing new paths to be carved. This underlying mechanism of enhancing cognitive flexibility may explain why psychedelic-assisted psychotherapy has shown promise in such a variety of illnesses. A potential unifying theme among these diagnoses is that of overly rigid beliefs, leading people to become stuck in maladaptive thoughts and behaviors. These are the deep grooves in the ski slope. By relaxing our models of the world, psychedelics open us up to new ways of seeing the world, allowing us to carve new paths in the snow. So that's how psychedelics might work in the brain. But what does it actually look like to perform this type of therapy? The most commonly used paradigm is called psychedelic-assisted psychotherapy. This involves one or a handful of high-dose psychedelic sessions, flanked by preparatory sessions before and an integration session following. During the preparatory sessions, the therapist will meet with the patient to build rapport and establish a trusting relationship. They will also go over what's frequently referred to as the flight instructions. These include reminders that, while you may have incredibly challenging experiences, remember that your body is safe and monitored. Be curious and brave. If you see a door, go through it. If you see a monster, confront it. Another important part of the preparatory session is developing an intention for the session, such as a focus on quitting smoking. Soon after the preparation will be the psychedelic session. This is typically an all-day event, lasting anywhere from 4 to 8 hours, depending on the substance used. Most protocols involve 2 sitters, 1 male and 1 female, who will be present throughout the session to offer a supportive, non-directive presence. The environment is intentionally designed to be as comforting as possible, more like a living room than a clinical office. Patients are encouraged to be introspective with the use of eye shades and instrumental music played through headphones. Although the therapists are there for support, the experience is driven by the patient's own thoughts and the effects of the drug. A day or 2 later, the therapist will meet with the patient again for the integration session. Patients share what they experienced, and the therapist helped them form meaning from it and integrate it with their lives. This form of therapy has generated a lot of hype over the past 5 years. This has included FDA designating psilocybin and MDMA as breakthrough therapies, a surge of interest from private equity, and the opening of psychedelic research centers at 4 major universities over the past 2 years. All of this hype is exciting, but it's important to keep in mind a few caveats. Although many of these studies are technically blinded, there are issues with blinding, since it usually becomes obvious pretty quickly when someone is on an acid trip. Also, this early research has been done in small, carefully selected patient groups. Many of them had prior exposure to psychedelics, and most were white folks from high socioeconomic groups. Still, the early results are quite promising, and there's some encouraging data from larger ongoing clinical trials. Another important caveat is that none of this research should be taken as promotion of uncontrolled use of psychedelics. These are very powerful compounds, as was discovered by the many ancient societies which only incorporated their use into sacrosanct rituals. Use in uncontrolled settings can be dangerous, and screening for things like a history of psychosis is an important part of the initial stages. A key lesson learned from the early days of psychedelic research is the importance of what's called set and setting, with set being your state of mind and setting being the environment you're in. The psychedelic state is one of high suggestibility, and your environment plays a strong role in how the experience unfolds. That being said, these chemicals are by and large quite safe pharmacologically, and there's essentially no evidence of classic psychedelics being habit-forming. One big question that remains is how will such a treatment be incorporated into our modern healthcare system? Clearly, this therapeutic modality is unlike pretty much anything used commonly in our practices today. These discrete, intense, episodic treatment sessions with potentially dramatic effects are more akin to something like ECT or even surgery in some sense. And for these reasons, we cannot conceptualize these psychedelic compounds like just a new class of pharmaceuticals. On their own, they may have some benefit, but it seems that their true paradigm-shifting potential lies in their ability to dramatically enhance the psychotherapeutic relationship. Total face time between therapist and patient can range from 10 to 20 hours. Figuring out how to scale that and make it accessible to everyone who could benefit remains an open question. So thinking back to Octavian, I think we all know patients like him who, despite daily medications and intense therapy, remain stuck in maladaptive patterns. Psychedelics represent an exciting potential future for these patients and for our field, one in which precise pharmacology is used to cause dramatic changes in brain function that ultimately lead to rapid and enduring healing. Thank you.
As we all know, Michael Mensah serves as chief resident of our residency program. Before he arrived to UCLA, he earned a master's in public health from the T.H. Chan School of Public Health at Harvard, where he received the prestigious Zuckerman Fellowship. He graduated from UCSF Medical School, where he participated in the PRIME program and co-founded the UCSF chapter of White Coats for Black Lives. As one of our 2 program chief residents, he supports each of us individual developing psychiatrists. He is known to frequently reach out to offer mentorship to junior residents, to know what's going on in each resident's life and how best to support them. It's difficult to comprehend how he even has time to do this, given his many, many various responsibilities, and it is all the more meaningful to know how much Mike values the well-being of his fellow residents. Beyond our program, Mike makes a big impact on the national stage in organized psychiatry and in leading medical journals. He is an APA SAMHSA Minority Fellow. He was nationally elected to be the APA Resident Fellow Member Trustee. He's published in JAMA Internal Medicine twice. One, a personal reflection on racism he faced as a Black medical student, and another, an analysis of the gender pay gap in academic medicine. This June, he published a frame-shifting opinion piece in the New England Journal of Medicine, in which he charges white physicians to take up a majority tax. He was recently named co-editor of the Racism and Mental Health Equity column for Psychiatric Services. He will leave a legacy of leadership and critical engagement here at UCLA when he graduates next June and joins the National Clinician Scholars Program at Yale. Today, Mike will be talking to us about the uses and misuses of race in medicine. Mike is actually at this very moment participating on a panel on health system racism at the National Health Leadership Conference, a panel that was rescheduled at the last minute. So he pre-recorded this lecture for us, a classic Mike move to be doing many things at once and be in several places at once. As a colleague, friend, and ally in gender and racial justice work, it is my pleasure to introduce Dr. Michael Mensah.
Thank you, Anne, for that kind introduction. As she said, my name is Michael Mensah, and I'm going to talk about race medicine and how to interpret racial identifiers in medicine specifically. So let's get right into it. Specifically, what I'm going to do is I'm going to talk about using the ACE method to examine biological race in medicine, and I'll explain what that ACE method is in due time. So there's 3 objectives I want us to achieve at the end of this session. The first one is, I want us to be able to differentiate between biological and social descriptions of race. This is a key skill. 2, I want us to recognize the origins of EGFR, or estimated glomerular filtration rate, and the differences in race that are purported to occur in our own electronic medical record. The third point is I want us to use the ACE method to appraise biological racial categories as they're used in the literature. And that's really the main skill I want us to work on. So in order to do that, like all things in medicine, we get right back to the patient. So imagine a 59-year-old Black male patient with schizoaffective disorder coming in. He's stable, he works for Maya Rudolph, he's taking clozapine and lithium. Labs are a little bit old, but everything seems to be good. He has no tremors, and his chronic illnesses are within normal range. You get some labs, and everything's fine except for his glomerular filtration rate, his kidney function. Curiously enough, on our EMR, you see that there are 2 different sections. There's literally a stratification for African Americans, who their estimation of their kidney function, and non-African Americans. If this man who appears to be African American identifies as non-African American, then he has stage 3 kidney disease. And if he does identify, then he has stage 2 kidney disease. Now, notwithstanding the many complications of whether or not lithium damages the kidney, or whether or not one should react strongly or quickly to any type of kidney damage appreciated in a patient, it remains important to be able to stage this man's kidney function. Does he have stage 2 or stage 3 kidney disease? Do we need to talk to his primary care provider about his blood pressure control? What's going on specifically with his kidney function? Does that change anything regarding our lithium? Regardless of what the answer to that question is, it remains curious that his staging of his kidney function is dependent in part on how he self-identifies as an African American. The question really, what this boils down to, is this African American identifier based on science? Is it based on how we identify him? Is it based on how he identifies? All those answers really are social answers, and yet we're talking about a biological output, which in some cases makes sense, but just categorically is not intuitive. And so it bears reckoning, and it bears examination. It merits examination. So that's what we're going to do. First, we're going to start with first principles regarding race, okay? Race came out of a social need to dissolve the cognitive dissonance between, on the one hand, enlightenment dignity, or in other words, the idea that all people have value, and the exploitation of people for profit. Both of these phenomena were coming up in mass during the 1600s, when slavery, really started to get some steam, and humans and human civilization had to find a way, or Western civilization really had to find a way to reconcile these 2 phenomena, because they were related, right? You don't have free time to think about one's dignity if you don't have someone else doing the work and giving you money. So as a result, this had to be rectified, and race helped dissolve the cognitive dissonance. It helped to say that the people who were being exploited are not human, or are less than human, or humanoid, but not actually human. And as a result, it helped create a social glue that remains to this day, and keeps us from thinking that we're bad people for exploiting other people. And so, throughout this process, race as a concept has mutated, and biologically, medicine has gotten caught up with that. Samuel Courtwright talked about drapetomania, or the desire for slaves to run away from their masters, and saw it as pathological because he assumed a biological inability of slaves to take care of themselves without the stewardship of their masters. And that assumption was was pseudo-biological, but was steeped in medicine. Samuel Courtwright was a doctor, right? And so what he said mattered based on people respecting medicine, or at least somewhat respecting medicine at the time, since it wasn't as respected a profession at the time. So that's how race started to become baked into medicine, and it continues to be baked into this day. And as a result, we should be skeptical about racial categories, especially as they pertain to medical outcomes without social context. And so let's look at an example of racial outcomes without social context. You see here that, on the Mayo Clinic website, there's it says that, basically if a baby is born, it has to have, a baby is born with sickle cell anemia, it has to have a sickle cell gene from both parents, and most sickle cell anemia most commonly affects Black people. This, because of our conditioning, looks like almost like a biological claim. It says that Black people are biologically more predisposed to having sickle cell anemia. Now, is that true? I think, in some degrees, yes, it is true. Is it complete? Absolutely not. There's a humongous omission between those two sentences, as you can see by this Nature article. This Nature article lays over the sickle cell frequency, sickle cell allele frequency with the endemic nature of Plasmodium falciparum or malaria overlaid with the allele. And you can see here that the allele very closely matches up with the endemicity of Plasmodium falciparum. So that's number one. It's, as we know, sickle cell is an adaptation to malaria. The second point is that the social context matters a lot too. The reason why, southern United States and Brazil have endemic malaria populations, as well as Europe, is because of the slave trade, right? And that's the reason why those regions have people who have this allele. Finally, the reason, some of the shortfalls of using race as a proxy all by itself, as if it's a biological marker, is that it would miss the endemicity that is contained in India, Saudi Arabia, as well as Europe, or specifically the Mediterranean. As such, would make you a worse doctor because you will miss you'll miss a large amount of people who could have sickle cell and could present similarly to someone in sickle cell crisis. And as a result, you'll miss those cases because you're based in race-based thinking, or at least biological race-based thinking. So that is a shortfall, and it's something gives at least more pause for us to be motivated to think about racial categories more skeptically. And the way to think about these racial categories skeptically is to say that, first ask about the racial category itself. How is it defined? How is it categorized? Once you figure that out, and make sure you figure that out, challenge it. Is it based on good science? Is it based on someone doing the research who you respect? Is it based on in a good publication? There's a lot of racial medicine, and a lot of people being paid a lot of money to study race. If someone's using a racial definition, it should be a good one. It should be something that people can agree upon in that context. Finally, is it being used correctly? Is the racial identifier biological and leading to a biological conclusion? Is it social and leading to a social conclusion? Or is there a mismatch between the conclusion type and the identifier type? In other words, are self-identified Black people is their self-identification being tied to biological outcomes without social context? And that's very important, because that's how we mislead people to think that social phenomena are actually biological ones, which then takes people off the hook. So taking a deep dive into the EGFR equations, this is a pretty straightforward case of using ACE, no rhyme intended. So looking at the equation, this is the equation for the estimated EGFR. You can see that there's a multiplier for being African-American, and you look at how the author Levy defined African-American. It was all about self-identification. He allowed people to identify themselves as African-American no matter where they came from, no matter what they looked like, and he believed what they said. So by definition, that's a social self-identification. The world told you you're Black, so you accepted it, and then you told Levy about it, and he accepted it too. So it's a social fact being used in a clearly biological multiple regression analysis to come up with an equation. Now, in explaining this social explaining this social identifier, the context he gives is purely framed as a scientific fact. Previous studies have shown that on average, Black persons have greater muscle mass than white persons. Nothing about why, nothing about the social reasons for that, just scientific objective fact. He uses 3 citations to cite this fact as if it is, again, biologically scientific. Going into those quotations or those citations, you can see, I don't have to go through all of them, but they're racially self-identified. Everybody who's in this study said they were Black, and it was accepted that they were Black. There's no genetic study finding a Black gene or anything like that. Not that that exists anyway, but there's nothing like that. And then because of that, and in addition to the fact that most of these studies were very small, 40 to 60 people, and are being forced to apply to millions of people, anybody who's gone to EGFR, it's clearly not, you can't extrapolate based on the data. So it fails all 3 criteria. You ask, the definitions weren't really clear, they're self-identified, you challenge them, they're not based on good data, and they're not extrapolatable. They can't be extrapolated, so it's not the best. And so the outcome really is that you have a 1.2 multiplier sort of delaying care for Black people when actually there's no evidence for it. And the solution for that is cystatin C. And you can use that instead of the creatinine to estimate filtration rate in kidneys, and it won't be race-based. One other example that's less studied in our practice is benign ethnic neutropenia. This is as we know, this is a different criteria for neutropenia for those who are Black, those who in some populations that are deemed Jewish, and this can be in Middle Eastern. And honestly, this needs to be explored more because there are racial disparities between enclozapine prescription, and ultimately this can lead to worse care for Black people as a result of perhaps dubious categorization of neutropenia and attribution of neutropenia to race. And so this is worth exploring. Using ACE to explore the benign ethnic neutropenia would be very fruitful in at least solidifying our confidence in that category and possibly debunking something that is doing harm to patients unnecessarily. So thank you, and I appreciate this opportunity. Thanks.
Hi, good morning, everyone. My name is Jared Greenberg, and for those who don't know me, I'm one of the psychiatry attendings at the VA here. It's my great pleasure to introduce a very unique presentation. This is actually a collaboration between 2 of our UCLA psychiatry residents. The first is Dr. Esther Kim, who is a first-year psychiatry resident. Esther began studying violin at the age of 5 and trained at the Juilliard School of Music, the University of Vienna for Performing Arts, and the Indiana University's Jacobs School of Music. She's been awarded the Most Promising Musician Prize at the Los Angeles Philharmonic's Bronislaw Kaper Awards and the European Union Art for Music Award. Esther is soloed with the New Hampshire Philharmonic, the Vermont Symphony, the Nagoya Philharmonic, the Seoul Sinfonietta in Korea, London Mozart Players, among others. She was featured as a musical soloist on Garrison Keillor's Prairie Home Companion. She has performed at Carnegie Hall, as well as the Kennedy Center for the Performing Arts in Washington, DC. At age 20, she produced a solo album released by King Records in Tokyo, and she performed throughout Germany, Italy, Austria, Slovenia, Spain, the United Kingdom, France, Japan, and Korea. Our other presenter, who will be our live presenter today, is Dr. Richie Loeb. Richie is a 4th-year resident whom I've had the pleasure to get to know during last year's clinical educator concentration seminars, as well as this year in our VA psychosis clinic. Richie has been playing guitar since elementary school. He joined his first band in 6th grade. You might have heard their 2 lead singles, No Free Tacos and Who Stole My Money? Those 2 songs, which you might not have known, narrowly missed winning the school battle of the bands, not 1, but 2 years in a row. Prior to medical school, Richie wrote and recorded an album for solo guitar and vocals, which, by the way, I highly recommend. One of those songs from that album will be featured today. Richie will be doing a forensic psychiatry fellowship at NYU next year. He hopes to continue playing music and enjoying music well into the future. So with that, I hand it over to Dr. Loeb. So take it away, Richie.
Thanks, Dr. Greenberg. And man, those first two talks were pretty rad. Let me just share my screen. Okay. Okay. So I'd like to talk a little bit today about the story of Narcissus and how it's evolved over time through narcissism to narcissistic personality disorder and beyond. And I'll show you today, with expert help, my own version of Narcissus' story. And here's one of my favorite interpretations of the story by Caravaggio. So my interest in Narcissus' story goes back to 2010, when I first read this New York Times article about the soon-to-be-released DSM-5. So at the time, the DSM-5 Personality Disorders Working Group had made a proposal to move the personality disorders from a prototype model to a dimensional or a spectrum-based model. So this would have meant going from our familiar clusters like A, B, and C with the prototypical personality disorders that we commonly think of, moving to each individual personality being described with traits on a spectrum or a dimension. For example, you could have traits of manipulativeness, extroversion, grandiosity, attention-seeking, empathy, etc. So this would have involved removing narcissistic personality disorder from the text altogether. So some bigwigs in the field decided to fight back, and you can see in the editorials that were written, the language was pretty strong, so the stakes were felt to be pretty high. So this was before I went to med school and before I even knew psychiatry was a field in medicine, actually. So I didn't know really anything about anything, but the idea that a diagnosis could just up and disappear seemed to me pretty radical. Now, to be clear, evolution and disagreement in the saga of Narcissus certainly aren't new. From the original myth in Ovid's Metamorphosis to the very recently discovered but likely older Parthenius text, there were already significant differences. In Ovid's version, Narcissus is so enamored with his reflection that he gazes until he turns into a flower, a narcissus or jonquil, whereas Parthenius has Narcissus so obsessed that he actually commits suicide at the end. Or again, in these two paintings, both turn of the century, but with very different styles and focus. The first, on top, draws our eye to Narcissus' own longing, while the second draws us to the spurned nymph Echo and her loving gaze. Needless to say, Freud, in his original 1914 text, there are many differences there from DSM-5, and DSM-5 itself actually kept the prototype model that we're familiar with and the dimensional model that I explained a little bit about earlier. And this presentation wouldn't be complete without at least mentioning millennials and Generation Z, who certainly have their own concerns about the topic. So as you can see, there are many different and rich interpretations of Narcissus' story through time. So now here's our version of Narcissus' story. And I'll tell you before we start, my two primary influences for writing this song are DSM and Ovid. And I can almost guarantee that no one has said that before. Let me make sure to share. Yeah. Okay.
Cover up the shambles, whitewash my decay, in glimpses of my beauty, on Narcissus by the lake. The dream becomes the body, substantial in its way. Perfection they will call me, For I'm the daffodil reflected in my dream. The stillest waters paint me as I seem, and echo whispers sweetly what I speak. It's not enough. And now she longs to see me, longs to sing my praise. And rightfully she grovels, oh Narcissus by the lake. I mustn't stir the surface. In stillness we will lay, and I will never hold him, oh Narcissus by the lake. For I'm the daffodil reflected in my dream. The stillest waters paint me as I seem, and echo whispers sweetly what I speak. It's not enough, for I'm the daffodil reflected in my dream. The stillest waters paint me as I seem, and echo whispers sweetly what I speak. It's not enough.
Okay. Thanks so much to the incredibly talented Dr. Esther Kim on violin, and to Dr. Rahel Gupta, Psychiatry PGY2, for filming, directing, and editing our music video. Kind of think she might have taken a cue from Collin and made the video extra trippy. Looks very cool. So as you can see, from ancient hubris to our humble concert to the inevitable DSM-6, there's so many ways to describe Narcissus. Like the blind men of the parable seen here, all describing different parts of the same elephant, each description is unique, but each adds richness, depth, and flavor to the overall picture. The fullest understanding of anything, be it elephant or psychology, requires science and art together, and it requires different perspectives in time, place, medium, emphasis, culture, and context. So I think it's fitting that psychiatrists play music. In fact, I'd argue a physician with a violin is uniquely positioned to understand, describe, and treat narcissism. In any case, thank you very much for listening to our version of this eternal story. We hope you enjoyed the show.
All right. Thanks so much, Richie, and thanks so much, Collin and Mike as well. So I wanted to open it up to have a Q&A. So we have a couple questions come in, but feel free to add some more questions as well as we go over the next few minutes. All right, and if you want to put also in the question, like who the question is directed towards, whether Dr. Loeb or Dr. Price, I think we should be able to figure it out based on context, but just in case, it might be helpful. We did have one question coming in for Dr. Price, asking if there's been any research on psychedelic use in patients with autism.
Yeah, it's a great question. I am aware of one study done by UCLA's own, actually, Dr. Charles Grove down at Harvard UCLA. He did a small kind of proof of concept study in patients with autism with social anxiety using MDMA-assisted psychotherapy, a couple of sessions versus placebo, and actually saw a very strong effect up to, I just looked it up, I think it's yeah, 6-month follow-up, they still had effect sizes up to 1. So it's just another example of where these substances might be very useful in patients who have kind of like constrained or rigid thoughts.
Thank you. And for Dr. Loeb, I really liked your discussion at the end about the idea of science and art coming together and being a better way of describing, or at least an additional way of describing a lot of the conditions that we treat. Was there something like about narcissism that stood out to you? Or was this kind of like an example that you chose, or was it something that you kind of had a special interest in? And perhaps are there other disorders or conditions that we treat that also come to mind as being kind of at the intersection of science and art?
Yeah, totally. Just happened to be the one that was on the chopping block, I guess, that the New York Times article was about when I did not have psychiatry on my radar, so I didn't know that like there were clusters or, you know, that borderline might be potentially an even more interesting topic to write a song about. Narcissism is obviously like timely in certain ways now, but no, I think, you know, especially for the personality disorders, but for pretty much all of the diseases we treat, I highly doubt that DSM-6 is going to solve everything and bring us all to one great agreement. So I think there will still be room for art and science in all of these.
Yeah, I agree completely. And for Dr. Price, I'd be curious to hear, you didn't go over this much in the discussion itself, largely probably due to time constraints, but there's a lot of political factors that go into our ability to engage people in psychedelic assisted psychotherapy. Do you have any thoughts or any suggestions on people who are interested in doing this but find themselves constrained? Like, are there any advocacy efforts, that sort of thing?
Yeah, great question. So there's a few groups that have been around for like 20, 30 years that have been doing a lot of kind of private advocacy, trying to make psychedelics kind of more respectable, more mainstream. MAPS is probably the most well-known multidisciplinary association for psychedelic sciences. And there's also the Hefter Research Institute. I think that you know, the main avenue where we're going to see these substances becoming incorporated into clinical use is through some of these bigger clinical trials. So MDMA is getting close to the end of phase 3 clinical trials for PTSD, and there's very promising results coming out of that in the early analyses. So I imagine that that'll get approved at some point in the next few years. And then psilocybin is one that's being used in multiple clinical trials for depression. And I think that'll probably come next in terms of getting approval. It's going to be, you know, it's going to require the regulatory changes ultimately, because all of these are still Schedule 1 substances. So the federal government, like cannabis as well, they think that they say that this is, you know, they have no medical use. And I think we can all kind of sense the momentum that's changing, but ultimately that will have to change before a lot of researchers can get their hands on it. Right now, it's a very lengthy process to get the DEA waiver for using psychedelics in research.
So even with those barriers, it sounds like you do foresee, at least hope, like in the next few years, there might be something tangible that has changed.
I think so, yeah. I think that's kind of the sense, that's where the momentum seems to be going. And like I mentioned briefly, there's psychedelic research centers popping up, and there's a lot of private industry interested in trying to capitalize on this. I think there's also a healthy bit of concern about maybe outrunning, you know, going a little bit too fast with it, kind of similar to what happened back in the 50s and 60s when these compounds were first discovered. They were used widely in psychiatry and in research, but then, you know, with the social upheaval of the 60s, kind of there was a lot of backlash, and that's what ultimately led to them being scheduled initially. So the hope, I think, is that we still can show that they're useful without kind of outrunning our runway and getting people against them again.
Thank you. And for Dr. Loeb, we had a couple of questions come in about whether people would be able to find the music video and or the lyrics to the music online. Do you have any plans to make that available?
Yeah, I think we could probably just distribute it to the people. I don't know the best way to do this, but I can like put the YouTube and SoundCloud links, send them to Ernie, who's running our Semel AV. Thanks to Ernie, shout out Ernie, thank you. And hopefully those can be like easily sent out to everybody who registered for this. So yeah, no problem.
Okay. And we can always put it up on the Semel Grand Rounds website as well if anybody wants to access it from there. Okay, and for Dr. Price, a question came in. Have there been any significant development in screening methods for weeding out potential psychoses and finding patients who might benefit from psychedelic treatment?
That's a really interesting question. Not something that I'm too familiar with. My understanding from all of these early small-scale clinical trials is that they do a pretty rigorous screen for psychotic symptoms in patients' histories and in family history of psychosis or bipolar disorder. I think with the idea that there's some concern that these substances, by kind of increasing the plasticity and cognitive flexibility, might actually be harmful in these psychotic states. But I haven't read much on people looking specifically into the effects of these compounds in folks with psychotic illnesses. I think it's a really interesting topic and one that I think definitely requires or would benefit from more investigation.
Mm-hmm. And a question came in. You had kind of approached this this talk largely from a research angle, but a question came in about how the pharmaceutical industry might potentially be involved. Are they mobilizing in response to psychedelics? Will we see potentially these consciousness expanding substances co-opted for profit, as has been in the story with other pharmaceutical compounds? And is there any response from the psychedelic research and advocacy community from that?
Yeah, another fantastic question. There is definitely interest in the pharmaceutical industry. I think we all know about like ketamine and the S-ketamine being, monopolized on for profit and maybe not more effective than just kind of the standard ketamine. And then there's a couple of companies, Compass Pathways and Usona Institute are two that are running the psilocybin depression trials. I don't know exactly how they, or if they plan to like patent it, if there's like a different formulation. I think the interesting thing is that there's the chemicals themselves, and then there's the therapy, kind of the whole package. And I think there's a lot of interest in how that therapy package is probably the most efficacious, and not just the chemicals themselves. So how do you make that into a profitable? How do you fit that into our profit-driven medical field? I think that's a challenge, and that's where the pharmaceutical industries will probably get really creative and come up with something.
Thank you. And a question for Dr. Loeb. When you kind of think about this intersection of art and science, you focus more specifically on music. Do any examples come to mind of like other media that have kind of caught your attention or that have stood out in terms of this intersection?
I know that our Dr. Justin Key in my class, he writes like fantasy and science fiction stories, and I think they certainly are at the intersection of mental health and art. I actually think his head talks 2 years ago, I want to say, it was about this. So yeah, for sure. You can actually, if you go to Amsterdam, you can see the 5150 that they got Van Gogh admitted to the hospital on. It's like written out in Dutch. It's pretty cool. I mean, obviously, I don't think it's called a 5150 per se, but it says, ex-patient chopped his ear off, no longer fit for, civilian life. So,
oh, wow.
Yeah, many historical intersections.
Yeah. All right. Well, we'll go ahead and wrap up the session for this morning. But just wanted to say thanks again, Dr. Price, Dr. Loeb, Dr. Mensah, for being here, for presenting on these fascinating topics. I did also want to give a quick thank you as well to Ernie Vasquez, who's been really helping run Grand Rounds behind the scenes and making sure that everything goes smoothly. So we're just so appreciative for all your help and all your efforts. And for everyone here, thanks for joining, and we'll see you again in early January. Take care.
Thanks.